You can start, Dr. Hartle.
All right, thank you. Hello, everybody. Welcome to Spine Time. My name is Roger Hartle, and I'm your host today. I'm the Neurosurgical Director of Spine Surgery at Weill Cornell, NewYork-Presbyterian Ox Spine here in New York City. And today, it is my great pleasure to have an interesting conversation about neuropathy, a very, very complex topic that we deal with in the Spine Center on a pretty much daily basis. Neuropathy essentially means nerve pain, but what is the scientific background? How is it being diagnosed, and how can we treat that? We'll talk about that topic today with Josh Weaver and Neil Mehta. Before I introduce our two speakers today, a few words about the Spine Center on 59th Street and 2nd Avenue that most of you have probably visited at some point. As you know, we focus on patients with all types of spinal problems, and we bring together a multidisciplinary team of surgeons, neurosurgeons, orthopedic surgeons, pain management specialists, sports medicine, neurologists, integrative health, and we all work together to diagnose the spine problem and then to come up with an effective way of treating it. We'll try to follow you through the diagnosis, the treatment, and the recovery period. Many of our patients show signs and symptoms of neuropathy or nerve pain. And it is my special pleasure today to welcome and introduce one of the co-directors of the Center for Comprehensive Spine Care on 59th Street, Dr. Neil Mehta, who is a pain management specialist. Neil, welcome.
Thank you, Dr. Hartle.
And then we have Dr. Josh Weaver, who is an accomplished neurologist and also one of the co-directors of the Center for Comprehensive Spine Care here in New York. Dr. Weaver, welcome and thanks for joining us.
Thank you.
So, as I mentioned, we'll talk about neuropathy, nerve pain. And I think this picture kind of symbolizes in a way what a lot of our patients experience, pins and needles, especially in the arms and the fingers and in the toes and the feet. This is something that I certainly see frequently in my patients who may or may not have a surgical problem. And it can sometimes be very, very difficult to diagnose and then also to treat. And before we go any further, I want to remind everybody here, please, if you have any questions, comments, concerns, use the chat box. We try to address as many of these questions that you may have as possible. Now, before we have Dr. Weaver talk a little bit more about peripheral neuropathy and what that really means, I just want to give you a short scientific background about this topic. We have the central nervous system, which comprises obviously the brain and the spinal cord. And when you have problems that address the central nervous system, those are problems that sometimes are being treated surgically, but then there are all these other problems that can arise from the peripheral nervous system, which is here in blue. And you can see that those nerves obviously travel all over the body, into the arms, the hands, the shoulders, and all over. And when something affects the peripheral nervous system, this can be very, very difficult to diagnose and then also very, very difficult to treat effectively. So Dr. Weaver, maybe on the next slide, you'll tell us a little bit about what is a peripheral neuropathy.
Great, yeah, thanks for that intro. Peripheral neuropathy is something that I see a lot as a neurologist. It really means that there's some kind of damage to the nerves directly in the arms or the legs. It's not really emanating from the spine. When we say peripheral neuropathy, it's the nerves directly in the extremities that are affected. You see here on this picture that there are all these blood vessels that really tiny blood vessels that go around the nerves. And the most common cause of nerve damage is diabetes worldwide. And what can happen is you can get damage to those blood vessels and also direct damage from the glucose to the nerve itself. But you do get damage to those blood vessels, and eventually then the nerve doesn't get as much blood supply as it should. And so you start to get damage to the nerve. When you get damage to the nerve, you'll get a whole host of potential symptoms. You can get numbness or lack of sensation. You can get tingling, like pins and needles. You can get burning kind of pain. You can get weakness in the muscles. So you can see a whole lot of different symptoms in the feet and the hands. That's the most common presentation. Though diabetes is the most common, there are literally hundreds of different causes that are out there, and we can talk about that a little later. But there's a lot of ways we diagnose it and do that workup.
Yeah, Dr. Weaver, thank you. And this is, I put this picture in here just to differentiate it for those of you who probably have had a spine problem that's more related to the lumbar or the cervical spine. Now, this is a drawing that shows you compression of the nerves in the spinal canal. And this can sometimes be a cause of a peripheral neuropathy as well, or can facilitate the development of it. But this is, for example, from a surgeon's perspective, something, this can be treated with surgery because we take the pressure off the nerves in the spinal canal. But this is really very different from what's going on in the periphery. And I just wanted to kind of point that out, that there are certain things that can be treated surgically, and that is compression in the lumbar spine or in the cervical spinal canal. But a peripheral neuropathy, for the most part, cannot be treated surgically. Is that correct, Neil? Or Dr.
Well, I think for the most part, but you and I have been involved in cases where there's, say, like a tumor outside of the spine that may be compressing one of these peripheral nerves that could be treated surgically. But you're right.
That is true. You can see here the nerves coming out. That's a very good point, Neil. You can see the nerves coming out here, and sometimes there are tumors indeed in the periphery, so outside the spinal canal, and they may be compressing just one nerve. And sometimes we can remove these tumors very successfully, especially nowadays with computer navigation, with the microscope, with minimally invasive surgery. And then we can treat a particular nerve, a particular peripheral nerve that's being compressed. But what we're really now talking about is peripheral neuropathy that really affects a multitude of small nerves that go into the arms and hands and feet. And maybe Dr. Weaver, you can talk a little bit more about the symptoms of, how do you know that somebody has a peripheral neuropathy?
As you've seen, the terminology can get a little hairy. So when we talk about peripheral neuropathy, it really could be any nerve outside of the spine, in any part of the body, really. When there's compression, whether it's a tumor or like carpal tunnel syndrome, you'll get what's called a mononeuropathy. One nerve will be affected. But usually when we use the words peripheral neuropathy, we're talking about what this picture is showing here, which is called a polyneuropathy. So all of the nerves kind of diffusely get affected. And so there's actually, this is the most common type that you see here, which is called a stocking glove distribution, because you can see the parts that are affected are kind of as if you're wearing stockings and wearing gloves. And the reason for that is, for a variety of conditions, including diabetes, the longer the nerve, the more susceptible it is to being damaged. And so usually the way neuropathy starts, it's a very sort of insidious onset. It's gradual over time, and it usually starts in the toes because that's the longest nerve. And then slowly it kind of spreads up the foot, spreads up the legs. By the time it reaches kind of where that picture is showing, the hands start to get affected. And this, sometimes you can have neuropathies that are very, very fast, within weeks. Sometimes the more common thing, like in diabetic neuropathy, it's a really slow process that can take years to spread.
There's a good question here from Tanya in the audience. What's the difference between a neuropathy and a radiculopathy? Maybe Dr. Mehta. So we can give Dr. Weaver a break.
Sure. Well, I think it's again goes back to his earlier discussion about the true definition. Is it more of one of the smaller nerves involved outside in the arms and legs, or is it something coming more from the spine, where you would think it's more radiculopathy? So that's one of the first ways to differentiate the two. The second thing is, I think he talked about mono and polyneuropathy. There's another question in the chat about that. Mononeuropathy being one nerve, poly being more than one. And so it's a little bit more of a wider spread condition when you get this polyneuropathy there.
Yeah, and I think the next slide kind of is a good example for neuropathy, right? This is a diabetic peripheral polyneuropathy, and maybe Dr. Weaver can talk about that versus if you have just one nerve being compressed from a tumor, like there's one question in the audience, a lipoma displacing one nerve, that would be a radiculopathy. But if you have diabetes causing these types of areas of nerve pain, that would be a neuropathy. But Dr. Weaver, maybe you talk about this.
Sure. So actually, I really like the picture that's there showing how the structure of the nerve, so you have different parts of the nerve that are affected. And so it gets kind of complicated in terms of neuropathy, that there really are a lot of different types. Part of what we do, we try to figure out what type of neuropathy you might have. The inner part of the nerve is called an axon, and the insulation that kind of surrounds the nerve is called myelin. And sometimes you can have things affecting the myelin. That's a demyelinating neuropathy. Sometimes you have things affecting the middle part of the nerve, the axon. Again, the most common symptoms that you get are the picture all the way to the left there, the stocking glove distribution that you see sort of diffusely affecting the hands and the legs. Sometimes you can get, parts of the nerves affected on one side. So you might see, this picture would be more like a radiculopathy or a plexus, like a bundle of nerves that's coming out of the spine. When that's affected, you might get just a part of the leg affected, or just a little strip of skin on the torso. Sometimes you'll get, there are disorders that are out there that sometimes you'll pick off individual nerves. So you'll see in picture C there, like one part of the hand, that would be like the ulnar nerve, then you've got the median nerve on the other side, and you've got the perineal nerve on the, so there are conditions that are out there, including diabetes actually, that for whatever reason, sometimes just pick off individual nerves. And so you might see that kind of pattern. And then lastly, you see sometimes, nerves go everywhere in the body. So most of the time it's the skin that we sort of feel, or the muscles, but also the organs can get affected. So there's a type of neuropathy called autonomic neuropathy that can affect the heart and the stomach, and the bladder. And so, there's really a whole host of things that can occur that can go wrong with the nerves. So part of it is just, talking to the person, finding out what's going on with them, and doing an exam and trying to kind of narrow down what's what.
Yeah, there's a question here about a neuropathy that involves the whole body, including the tongue, which is quite interesting. Does that make you think more about maybe medication or systemic causes, or chemotherapy or something like that causing a neuropathy?
So for sure, I mean, if you have nerve problems literally through your whole body, it's got to be something diffuse, right? And so that could be medication or toxins, that can be diabetes, that could be vitamin deficiencies, that could be metabolic problems like with your thyroid or your kidney. Sometimes that can cause nerve issues. Autoimmune diseases like lupus or rheumatoid arthritis, those can lead to nerve issues. And because nerves are everywhere, if it's a bad enough neuropathy, you can feel it everywhere in your body.
Yeah, so that brings us to the next question: how to diagnose peripheral neuropathy. And I can tell, and I know from experience, obviously, treating patients with spine issues, that it can be a real challenge. And it can sometimes lead you down the wrong path if you're trying to make a decision in terms of surgery. So you got to make sure that you don't get fooled by some presentation that may suggest a surgical problem versus it turns out to be neuropathy, which is not surgical, right? So how can you avoid that, and how can you diagnose a peripheral neuropathy accurately?
Yeah, that's a really key question. I mean, sometimes it's obvious, you have shooting pain coming from your back down your leg, and it's very clearly, the patient will just tell you, this is what's going on with me, and that's what's happening, and it's one-sided. But sometimes it's complicated, and you can have someone who has two things going on, or they can just have really bad burning pain, and along with back pain, that's common, and so sometimes it's hard to parse that out. So first thing is that thing on the left there, a physical exam. I mean, you get the history from the person, you do your exam, you look at their reflexes, you look at their sensation, temperature, and vibration, and you check all these things, because this is all the different ways the nerves give information to the brain. And then I actually probably wouldn't start with blood tests. Usually what I do at that point is that last one over there, the electromyography. And so what we do there is when we think someone has a peripheral neuropathy, we use electrical stimulation, and we can actually monitor and look at these nerves, and we can see, are the nerves damaged? How bad is that damage? What parts of the nerve is damaged? Once we have a better sense of what kind of neuropathy is going on, then we often will do blood tests. And that's where you look at, diabetes, and you look for thyroid problems and kidney problems and vitamin levels. And you really do a bunch of blood tests. You try to see if there's anything that you can fix, right? If there's anything that you can treat, it might help heal the nerves.
I know.
Yeah.
I'm sorry. I know that
No,
a lot
no.
of patients are worried about getting EMGs because of the needle stick.
Yeah.
Is there something that we can tell patients to reassure them or to
We actually did a webinar with Dr. Weaver and Dr. Sun talking about EMG in particular, and it was really enlightening about how it's really going to a good center like working with Dr. Weaver can make the experience so much better.
So
I would say it's not the most pleasant test to go through, like many medical tests. It's, no one wants to do it for fun or anything, but if done correctly, it's actually not really all that painful. It's maybe mildly uncomfortable, I would say. But different places do it differently. I think if it's done appropriately, it's really not too bad.
Now, there are a lot of questions here, and a lot of these questions we're going to address on the treat, because we're going to talk about treatment. But maybe real quick, there's one question about metformin. Is that a common? I know we had it on that list. Is that a common medication to cause neuropathy?
It can be. So one of the problems with metformin, although it treats diabetes, which is one of the causes of neuropathy, sometimes your vitamin B12 levels can be depleted with metformin. So you have to be really careful when you take certain medications that there's not some other side effect that can then cause problems with nerves. But as long as your doctor knows about that, which most do, they can check those levels and nip that in the bud before it becomes an issue.
Okay, let's go to treatment. I think there's a lot of interest in the potential options for treatment. So some questions about vitamins and supplements. Any of you, does any of you have any comments about the ones listed here? This is just an example of supplements that I recommend to some of my patients who have neuropathy in addition to a surgical problem. Any thoughts about this? Is there any evidence, anything that's more supported than other things?
Well, if I can just take a moment, I think Dr. Weaver really hit one of the major points, is that a lot of this is good history and trying to figure out the story along with the examination and testing to find an underlying cause. And when possible, try to treat the underlying cause rather than, first step being the vitamins and so forth. For example, if you have shingles related post-herpetic neuralgia, that, we focus in on that rather than having to use, vitamins and so forth. I think, I don't know, Josh, if you think these are more second line or third line rather than the first stab at it?
Yeah, I would say I agree with you. The first step is really just trying to find an underlying cause, and then you treat that, right? Because if you do that, then the nerves can actually heal. So that's always the goal. But, in the most common kind of neuropathy, like the axonal neuropathy, 1 out of every 3 people, you do all the blood tests, you can't find anything, and that's a really frustrating situation. We call that idiopathic neuropathy, and that's just the word meaning we don't know. We don't know what the cause is. So actually, before I jump to supplements, although sometimes I will put this in, especially if patients don't really like medication or they've tried medications and it didn't work, there's a lot of prescription medications that are out there that treat nerve pain. And I don't know, Neil, if you want to go over a couple of the common ones that we use, that's probably where I would start with most people because there's more evidence for those.
Yeah, I don't know, Roger, if there's a slide on some of the gabapentin and other type drugs.
No, we don't have it.
Probably the most common medications used in neuropathy are very familiar to our viewers. Gabapentin, also known as Neurontin, Lyrica, also known as pregabalin. Those are old anti-seizure drugs that have been used for years in other types of nerve pain, and probably started out in treatment of shingles-related neuropathy, and then evolved into treatment in other areas. One thing about the neuropathic pain or neuropathies is that there's a lot of commonality between the medications. The other class of drugs that are used are some of the old antidepressant drugs. Again, drugs that have to be taken on a regular basis and probably need some titration upwards, need a little bit of patience to see a benefit. But these are drugs that have been effective, but they take a fair amount of time and they're not perfect. They do have side effects like feeling drowsy, blurry vision, maybe even in some of them you can gain weight, you can get dizzy. This is some of the challenges that we have with those medications, and why we often will use what we call multimodal treatment, which is not just one medication, but actually try 2, 3, maybe 4 different things, ranging from pills to vitamins to topical agents, maybe even intravenous treatments that can treat neuropathy.
So there's a lot of interest here in terms of what is the prognosis, so I think it is fair to say that for a lot of these neuropathies, they can be at least symptomatically treated successfully, even though sometimes you can't identify the cause. Is that correct?
Absolutely.
Absolutely, yes.
So there's a lot of interest in supplements and more natural ways of addressing neuropathy. Let's talk about some of the vitamins.
Yeah, so I know a bit about this, and the ones that are listed here are actually probably have the most data. You'll if you look online and Google, you'll find like 50 different supplements that are out there. Most of the supplements that you'll see online don't really have a whole lot of data to back them up in terms of really helping the nerves. There's a lot of theory behind it, but there's just not a lot of strong data. Alpha lipoic acid, that's been looked at in diabetic neuropathy, although a lot of people who have any kind of neuropathy often will try to use it. And it does show that it can help. The studies particularly looked at the IV form, which obviously most people aren't getting. They're getting the oral pills. So hard to know if, how helpful it really is. I can tell you anecdotally, I have patients who are on all of these things from time to time, and some really do feel like it helps, so it's reasonable to try. The B vitamins, especially these B complexes, they usually have B1, B6, B12. Those can be beneficial because a lot of the nerve cells use these B vitamins, to stay healthy. You do have to be a little careful with those because B6 is really the only B vitamin that when there's too much B6, it can actually be damaging to the nerves. So you do have to be a little careful if you're on a multi-B vitamin to check those levels periodically because you don't want to do the wrong thing there. Turmeric or curcumin has some data for nerve pain, and it seems to help. It's an anti-inflammatory agent. Same thing with the omega-3 fatty acids. And again, some data, it's pretty weak data, but most of these things are generally not going to hurt you. And I think it's worth a try, and especially in conjunction with other treatments.
Medical marijuana, any data on that in peripheral neuropathy?
There's actually quite a bit of data for medical marijuana. In New York State, where we are, there are, it's one of the diagnoses that will qualify you for medical marijuana. So if you have neuropathy, you would qualify for that. I generally don't use that as a first line agent because the prescription medications have way much more data to back them up. But if people have tried a medication or 2 or 3 and nothing's really working, medical marijuana is a pretty reasonable option.
So what about acupuncture?
I don't know, Neil, do you particularly use acupuncture or?
I do. I mean, for patients that have tried many of the other more conventional treatments, we think outside the box. And I know you and I have talked about this before. Acupuncture is pretty benign, and usually 5 to 10 sessions can give you an answer on whether it's going to be helpful. And there really is very low risk to it. And many insurances are now covering the treatment.
So before we come to another potential surgical treatment, let's talk about home remedies. My grandmother used to say that garlic is good for everything. So, so what about neuropathy and home remedies, garlic and anything else?
Well, I'm married to an Italian, and he cooks with garlic pretty much every meal, so I get a fair amount of that, so I think I'm good. I don't know the data for garlic and neuropathy, to be honest. I do think it can thin the blood a little bit and can be good for circulation. There might be some data for that, which, as you saw from that other picture, the nerves, they have that really delicate blood supply, and so maybe that's one way it could help. I'm not sure that there's a whole lot of data for it. I think it's interesting, the home remedy on the other on the right there with that little green smoothie. If you eat a really well-balanced anti-inflammatory diet, and you're getting a lot of veggies, for sure, that's going to be good, just in general for nerve health. So there's a lot of stuff out there. As long as it doesn't seem harmful and have you kind of use good common sense with it, it's probably a reasonable thing to do.
It's funny how the Hindu culture also believes in garlic and ginger and turmeric. So we have common ground.
For sure.
So let's swing back and talk about something that we've been involved with here a lot. And I know Neil, obviously, he's published and is really one of the pioneers when it comes to this type of treatment for selected patients. Maybe Dr. Mehta, tell us a little bit about stimulation.
Yeah, so stimulation has been one of my research interests. And what it essentially is, it's like a pacemaker for the spine or nerves. So rather than using medication, can we use electrical activity to try to slow down or maybe even totally block the painful nerve firing? And it involves wires and a battery to power the electrical signal. And it's all implanted so that you can, not notice that it's actually doing anything on the outside. One of the things that we're really excited about is that we've spent a lot of time talking about diabetic neuropathy and how it's prevalent, and it's often very challenging to treat once it happens. Gabapentin, Lyrica are sort of the main treatments, but they have a kind of a low success rate and a lot of side effects. So we actually did a study here across with some other big institutions where we took patients that had diabetic neuropathy and had tried these medications and didn't find benefit. And we tried to tweak the doses, but also randomize them to potentially have the stimulation therapy. And we found remarkable results. So 88% of the patients that switched from gabapentin to stimulation went on to have meaningful pain relief and actually went ahead and had the device permanently implanted in them. And using that evidence together, we had about 200 patients in the study. We were able to go to the FDA and actually get approval and insurance coverage for this treatment for diabetic neuropathy. So something really, I'm proud of our spine center to be able to help that. And for many patients, they may know this therapy because this has been established for a long period of time for spine-related pain due to pain down the legs or so related maybe after spine surgery that didn't help, or if spine surgery is not an option. I know that doesn't happen here at our spine center where anything goes wrong, but it's a great treatment, and I think it's really going to be something that more people will learn and get benefit from. So something to consider and have a discussion with one of our doctors here.
That's quite remarkable. There are a number of questions regarding spinal stimulation here. One question is this a temporary solution or does the pain come back after a while typically?
Yeah, it's thought to be a permanent solution. We actually track the data out to 2 years. It becomes difficult to run studies for longer than those periods of time, but we still see these patients and they continue to do well. But obviously nothing is perfect, and some patients may progress in their disease, and if that happens, the pain may return, and so we have to relook at what other things we can do. There's also a temporary version of it, so you get to test it out yourself before you have it permanently implanted to know if it's right for you.
Yeah, that's the beauty of it. That's what I tell patients sometimes, that this is not necessarily a commitment, a lifelong commitment. You can do the temporary testing and then see if that works for you. There are a few questions about radicular pain, sciatica, and stimulation. And I can just maybe chime in here and say that if you have radicular pain or sciatica, then obviously you have to figure out, or the physician has to, or in the spine center, we have to figure out, is there an underlying reason for that pain? Is it, if it's, for example, a herniated disc, then the treatment may be just physical therapy, an injection, or maybe a small operation. But there are patients who still have radicular pain even after a technically well done and successful spine operation. And in those patients, sometimes stimulation can be an option, correct?
Absolutely. And sometimes the spine operation would be really challenging to do, given sort of the overall health of the patient. And maybe this is a viable alternative for that spine operation. Say if somebody's, older or has a lot of medical issues otherwise.
Then there was a question about occipital neuropathy. Is stimulation the treatment for that, or what would you do for that?
It's certainly an option. It's not the first attempt at trying to treat that. There's certainly injections and maybe even decompression surgery, depending on the reason for the occipital neuralgia. But stimulation has been used in that arena.
So there's so many questions here, and a lot of really, really good questions, and it would be amazing if we could get to all of them. Maybe we should pick up the topic again at a later point and maybe pick some of these questions and focus in on those during another webinar in the future. In the meantime, though, I want to thank you both for your time. I think this was very, very informative. I certainly learned a lot about what we do in the Spine Center. Maybe Dr. Weaver, a few words at the end for the participants and for the patients in terms of how to address. I know there's still a lot of questions and concerns about neuropathy. What's like a general approach towards a neuropathy?
Yeah, I think I would just point out that not all neuropathies are the same. There's a lot of variability. So if you go to someone who understands that complexity, they can help try to navigate this whole thing, and I think there are, even when you can't figure out the cause, there are a lot of ways to treat the symptoms, as you've heard here. And I think you should never lose hope. I think there's so many different options that are out there. It's not just one or two pills. I mean, you have a lot of natural remedies and a lot of prescription medications and a lot of procedures and stimulators and all sorts of different things that are out there. And more things we're finding, every year. So I think, it's a really interesting field. And I think if you have this issue, there's a lot you can do about it.
And as we're finishing up now, and people are going to go home, have a glass of wine, is there a concern with alcohol and neuropathy? Maybe a closing remark, Dr. Mehta or Dr. Weaver.
I would say that alcohol can be the treatment and potential cause of neuropathy. How's that for a vague answer?
It's the dosis facit venenum, right? It's how much. So be careful. All right. I wish you all a pleasant evening. Thanks for calling in. And we'll be back in 2 weeks with another Spine Time webinar. I think it's going to be about global health. So we'll see you hopefully then. Have a nice evening, and thanks again for being part of this.
Thank you and good night.
Thanks. Good night, everybody.
Bye-bye.